All right. We're on the home stretch. Thanks so much, everyone, for coming, lasting out the very last bit of the conference, hour and a bit left. Jason Grebley, and I'm joined by my co-chair,
Sharon Hutchinson from Glasgow. So it's my pleasure to, we've got a series of presentations here. We're going to get some feedback from a whole range of different sessions and areas, and I'd like to welcome Lise and Louise, who are going to give us a summary of their networking event. Please welcome everyone.
Hello. Is it on? So the five of us have been gathering for the last several months over Zoom and planning a networking session, which Louise is going to explain in more detail. It's been amazing. It's been amazing connecting before the conference and during the conference. And sadly, MJ couldn't be here. Visa issues, of course. But this is the photo that he shared from a previous INHSU event in South Africa. And there are the four of us taking a selfie at the actual event.
Yeah. So one of our objectives was, in previous INHSUs, the academics have kind of been over here and the community have been over here, and never the two shall kind of meet. So one of the things that we wanted to do, and there was, I guess the perception might have been that the community were really scared of the academics, but actually I think some of the academics were really scared of the community. And so actually bringing them together in a really informal way, and do you know what, we didn't know whether it was going to work. We didn't know whether people were going to turn up, and it was just incredible. I mean, the noise level was like up there. But people came together, and we just went through, we gave people some questions to, just to break the ice and just to chat. And this was some of our feedback. I mean, the most hilarious one that I saw was somebody reflected that they only got to talk, like 2 minutes wasn't long enough, and they only got to talk to two people. Well, clearly, because we did it over 20 minutes, clearly they didn't actually stick to the 2 minutes anyway. But I think it was definitely a concept that Lise, Rachel, Jason, and MJ and I will definitely try and build on. The name tags, we literally the Tuesday, for any of you that have been to the INHSU preliminary things, like you've got the INHSU prisons, you had interventions, you had the board meeting, you had the community day, so it was just bang, bang, bang. So we didn't really have enough time to kind of get the room set up. There were some last minute changes. So we had to really think on our feet. And I'd just like to extend thanks to everybody that came and just went with it as we kind of changed things as we went. So this was some of the feedback. And I mean, I really liked although awkward and out of my comfort zone, it was actually a great way to connect. This was lovely. I was forced to people were forced to come and talk to me. You know, we had really genuine feedback, and it was just, yeah, it was one of those moments when I go home and I kind of, you just reflect on what we were a part of and what we helped bring together, and we've actually seen people gelling together at the conference. Do you know, when I've brought two people from our community up with me, and every time I turn around, they're talking to somebody else, and it just warms my heart. So yeah, and I'm probably out of time. That's all.
We may write this up for a commentary piece in a journal and some community-based publications. And so we have been advised that we should say, if you do not want your quote used, to please email us. Thank you.
Although they've probably already gone home.
They've gone, so it's fine. I've said it.
Thank you.
Thank you.
And just a massive thanks to the team. They've spent so much time and effort to pull that together on their own time, and it's just an amazing addition to the conference, so thank you so much. Okay, so it's my pleasure to introduce the community rapporteurs, plural, I think. And so it's my absolute pleasure to introduce Carrie-Anne Calhoun from Turning Point Scotland, and also a close friend, collaborator, colleague, Sione Crawford from Harm Reduction Victoria. So over to you guys.
Oh, so it's on. So hi everybody. So we've got one slide. First of all, I want to thank INHSU for asking us to do this. To feedback and reflection. Nikita had asked me to do a rapporteur, and I'm like, and what does that mean? And it's like, it's a reflection now for a community perspective. So what I'd done today was I went round all the community committee members and had asked them to give me a wee quote on kind of what they've took from the conference. So you'll see wee quotes up here, so I'm not going to read them all out. I think you can read them yourselves. So over the past kind of couple of days, it's been absolutely amazing. Now it's been great connecting from other people now from all over the world, and it's been amazing to have that opportunity. So again, I really want to say thank you. Speaking to one of the community members that couldn't actually be here today, Jason Wallace, I'm sure you've heard him, he was up here now kind of speaking a lot. I'd asked him about now kind of what one of the kind of things now that he took out at the conference. And he said, and I agree with him, how the kind of open session, having community members with lived and living experience now up on the stage opening INHSU was absolutely fantastic. And I also asked another community member, and I'm kind of looking about to see if I can see him, but he is in the room. And I had asked him for a wee quote as well, and he had given me a quote, so I'm just going to read this out. So the quote that he'd given me was the work that was done by Dr. Harris regarding access to OAT for the inpatient in UK was extremely important, and he hopes that it encourages doctors and gives people the medication and treatment that they need to be able to access better treatment in hospitals for the future. And again, kind of reflecting and listening to, again, Jason Wallace and also a few other kind of community members and how he's speaking about and emphasising now the importance and not only peer workers but also paid peer workers, and that's the kind of feedback that we got from the actual community day as well. We've had a lot of talk about a workshop that was attended yesterday, and it was Matt Smith from the Caledonian University that put on the workshop, and it was absolutely fantastic. There's been loads and loads of talk from the community members from it and how they felt valued within the workshop and how they felt listened to. And it was really well attended as well. There was actually, I think it was 60 people, but I think the numbers kind of increased a bit. So now thank you to Matt now for that. And also, where am I now? Sorry, I've lost myself. So one of the kind of biggest feedbacks that we got was the fixed needle exchange that's on the premises now of the conference. There was a lot of community members and how that had attended and they felt really welcomed and really valued, and especially people that are coming from other countries that needed wound care and stuff. That was available within the conference and also outside. One other feedback that we had got that they just wished how that there was more kind of community members presenting than what there was. I'm making sure I don't miss anything out in case I get shouted at. I think that was it. But what I'm going to do is I'm going to pass you over to Sione, and then I'll take it back for final remarks.
Thanks, Carrie-Anne. I'm subbing in for Jason, but neither he nor Rachel, who were the community co-chairs, could be here this week at this particular session. So my reflections are really that there were so many highlights, both across research and practice and, of course, community. And that's what I'll focus on. Anne Livingston and Magdalena Harris both reminded us at different times forcefully that people who use drugs and peers can force social change for the better, and we must be seen through a human rights and capability lens and not through a deficit lens like we so often are. This was underlined by the presence and leadership from some amazing community people and leaders who are here from around the world that I was really honoured to meet and get to know. more. I kind of had a list of names and I thought I'm going to miss people out, but they are like in this room right now. So the ones I can see just in front of me include Matt Bond, Ange McBride, Nards and Sam from Australia, and many others. Lynn Russell's over there, and Matt, anyway, there's heaps. That would have been fantastic. But on the other hand, at least 3 times Matt Southwell was able to get in some reflections and remind us that our networks and organisations can actually also be destroyed by malign forces, as I call them, and so they really have to be protected and made safe so that our voices can be raised without fear. The Community Committee and chairs, Jason and Rachel, and all of the community members from Scotland, Northern Ireland, Wales and England, I want to thank you all for welcoming us from the rest of the world and for making things easy for us, if you know what I mean. And I just want to finish with one quote from Koketsu, from Sampud, and he said, I've never felt so loved and such a sense of inclusion at a conference, and I guess that's what sets INHSU apart. So I'm going to hand back to Carrie-Anne.
Thanks, Ione. So lastly, I would just like to say a big, massive thank you to Nikita, Brooke and Leah now for opening up our rooms for our meetings. I know it was very early in the morning, it was 6 a.m. in your time and 9 p.m. our time, and I've just loved every single minute of this conference. This was my first conference and I hope that it isn't my last, so thank you.
Thank you so much to Carrie-Anne and Sione. I'd next like to welcome up Sophia Bartlett, who's a senior scientist for sexually transmitted and bloodborne infections at the British Columbia Centre for Disease Control. And Sophia is going to give us feedback on epidemiology and public health.
I would like to start by saying congratulations to all of you who are still here and awake, because this has been a marathon, not a sprint. And I would also like to say thank you for everybody who has shared their personal experience, their knowledge, their expertise, their research. It's been amazing. And I could have made this talk go for hours. So the first thing that I wanted to touch on was the negative impacts that the COVID-19 pandemic and global conflicts have had on the health of people who use drugs. Jack Stone opened up the conference with this one, and I mean, he did mention that his modelled scenarios are likely pessimistic, but I think it's very clear from this data that a large number of preventable HIV infections, hepatitis C infections, and deaths may occur among people who use drugs in the Ukraine as a result of the Russian invasion. And I think of note, there may be even more significant impacts on people who use drugs in Russia, which we've not really even scratched the surface of, I think. And so, you know, I think really, again, echoing that human rights lens, that people who use drugs in Russia didn't choose for that invasion to happen, and we really do need to pay attention to what's happening in Russia. And this was the data presented by Sotirios Roussos. This was one of only a few abstracts at INHSU this year that was presenting recent biobehavioural survey data with incidence estimates for HIV or hepatitis C infection. I think this is a warning because it's possible that incidence rates may have had similar increases in other settings globally where services were disrupted by COVID-19. However, because we're not actually measuring incidence either through longitudinal cohorts or biobehavioural surveys, we just haven't detected them yet. And I was reflecting on the situation in Canada where I live and work, and we've seen the incidence reported to public health drastically reduce over the past 2 years. In fact, from the incidence reductions, it looks like Canada's on track to eliminate hepatitis C, but that's simply because testing has been eliminated. And when you don't test, you don't diagnose. So I think we really need to think about methods to measure incidence, whether it's modelled or other, and I'll comment again on this later. The key theme that I also want to mention is around fentanyl or whatever other thing comes next. This isn't a new drug scare, it's more a plea. And I really felt yesterday sitting in the Safer Supply panel, it was like a scene out of Don't Look Up, where the scientist is on the news saying that there's an asteroid coming for the Earth and you're all going to die. And everyone's kind of like, what about the economy? So after living in Canada for 4 years and witnessing the absolutely devastating effects of fentanyl and now benzos with fentanyl, I really have to say that where we have a illicit drug market that's driven by profit, it will continue to evolve and change. And usually it's evolving to make more money, which does not actually help people. So, and on top of that, drug preferences also change. Safer supply is one solution. It is not the solution. Decriminalisation is one solution. It is not the solution. Legalisation surely must fit somewhere in there. But we do still need more evaluation of the different models of safer supply, including medical prescribing, compassion clubs. And I hope that some of this data is going to be coming out of Canada in the near future, but I surely hope that there are other places in the world that are able to do something like this, because if it's possible in Canada, it is possible in other places. And I just hope that I'm not going to come back to this conference and somebody here has, somebody here has died. Which brings me to the next key theme. Oh, God. Mortality is increasing among people who use drugs, despite increasing hepatitis C uptake and cure. This is a really interesting study, which I have to admit I am a co-author on, so I am biased. But what this shows is that among people cured of hepatitis C infection with DAAs, their mortality is still considerably higher compared to the overall population. I think this really, particularly for the people with, this was compensated cirrhosis or decompensated cirrhosis at the time of cure. So it's not developing it afterwards. So that person should have been being followed for HCC after achieving SVR. And I think we've shown here there's a very good opportunity, or an important opportunity, to look at the HCC surveillance that people are receiving and really understanding if we could do a better job there. And also a need to continue to monitor mortality among people cured of hepatitis C infection, as well as the overall population of people who use drugs, in order to ensure that our efforts are going to the right place. This is, I think, something that we all knew, but is interesting nonetheless. I think hepatitis C reinfection is really driven by low levels of hepatitis C treatment in the overall community. This was presented by Nora Parmentier, and I think this evidence from Tayside suggests that when certain levels of hepatitis C treatment uptake at a population level is achieved, you start to see the reinfection rate declining. I would love to know if this pattern is being seen elsewhere. So my take-home message is, if we're treating more and more hepatitis C infection among people who use drugs, but morbidity and mortality is continuing to increase, or is in excess compared to the overall population, is hepatitis still the right thing to try and eliminate? I don't know the answer, but I think we all need to think about that. So future efforts required to advance epidemiology and public health. We can't manage what we don't measure. Efforts are needed to improve and increase the monitoring of hepatitis C incidence among key populations, such as people who use drugs and people in prison, to ensure that we're able to monitor progress towards this target. I think we all maybe forget, or at least need reminding, that incidence reduction is one of the key elimination goals. And obviously, if we all could go do things over, we might change some of those targets. Nevertheless, I think monitoring incidents at a local, subnational, national, international level is still really important. And then the next piece is more attention to hepatitis B and maybe hepatitis D among people who use drugs and people in prison. Surely there are people around the world who use drugs who have chronic hepatitis B infection, but I didn't see any of that data here. So I think we need to think about addressing that and answering some of these key questions. How many people who use drugs have chronic hepatitis B infection? How many have a detectable viral load and are eligible for treatment? What's the treatment uptake currently like? And I think this is a key question that none of us really know the answer to. What is the anti-hepatitis D prevalence among people who are hepatitis B S antigen positive? Since I started working at the BC Centre for Disease Control, and I get surveillance reports all the time now, we've started to see these hepatitis D diagnoses among people who are triple and quadruple infected. So they're living with hepatitis B, hepatitis D, hepatitis C, and HIV. And I can't help but wonder, where did they get that infection from? I suspect we actually might have local hepatitis D transmission, and it's probably in other places too. And when we've gone back and looked at who's actually getting tested, it seems very random. We don't have a systematic application of hepatitis D testing, and I would really urge people to think about whether that's something that is maybe worth addressing in wherever they're working. And finally, I would like to call on two more terms to be left in the past: unengaged patients and hard to reach patients. And we really need to wonder, is it hard to reach groups or hard to reach services? I'm sure this has been said before, but I'm going to say it again and again. There is no such thing as hard to reach people. There's hard to reach services. Thank you.
Awesome work, Sophia. Thanks so much. Our next speaker is Tommy Brothers, who's a physician and PhD student in epidemiology and public health at the University College London. He is also a resident physician training in general internal medicine and addiction medicine at Dalhousie University in Halifax, Canada. And Tommy's going to go through the clinical science rapporteur.
Thanks very much, Jason. And thanks everyone for sticking around. And thanks to everyone who sent me your slides and answered my emails and all the discussions this week. There was an incredible amount of learning. Thanks to the INHSU staff, Brooke, Leah, and Nikita in particular, for helping facilitate this. I was trying to come up with some key themes in terms of like lessons learned or final takeaways. And I think after this conference, I'm walking away with many more questions than answers. These are one attempt at trying to summarize the key questions I'm reflecting on as a clinician and a physician who's interested in improving care for people who use drugs and caring for people who use drugs. We heard a lot of great examples of local champions implementing clinical services and really effective clinical science in their setting. And I'm going to show you some of that. That's really exciting and inspiring. But I think much more common at this conference, we heard from people who use drugs, from community members and qualitative research amongst those groups about what people were missing in terms of clinical science and clinical care. That they wanted relational care, they wanted long-term, comprehensive, flexible care with lots of options where they could set their own priorities, and that was missing in most places. So how can we deliver clinical and healthcare services that people who use drugs actually find useful and are interested in engaging in because it helps them and meets their priorities and aims? Number two is how can we push the scope of providers to offer comprehensive, flexible, and long-term care, especially in settings of austerity and constraint. This theme came up over and over, and Sophia highlighted it in her rapporteur session as well. You know, a local dedicated initiative to do hepatitis C microelimination is laudable and it's wonderful, but there was lots of descriptions of people entering that care setting and needing lots of other things, or looking for lots of other things and not being able to find it. And number three is how should clinicians and clinical researchers think about health interventions that promote dignity and human rights, but have insufficient or mixed quantitative evidence? This, I think, is the most challenging one for me personally. Magdalena's presentation this morning I found particularly inspiring. I'm going to be thinking about that for a long time. We heard about an evidence review from the European Monitoring Center on Drugs and Drug Addiction, finding some insufficient evidence for harm reduction programs, and yet we're hearing from the community that these are things people need to be well and to engage in to tackle other health issues. It's hard to measure some of these things. And so I think we need to get creative on the clinical science front about how we can embrace and align human rights approaches with evidence-based medicine. So here's just going to be some examples of those reflections that maybe somebody will have some answers or we'll have some new questions at the end. So the first batch of presentations I want to highlight demonstrated innovations in patient-centered opioid pharmacotherapy. There was some great discussions, a dedicated session, and the INHSU exhibit on choice in opioid substitution treatment, opioid agonist treatment, and appropriate critical reflections on control and surveillance in opioid agonist treatment, descriptions of alternate OAT medication options, and then a dedicated session on safer supply prescribing. So Professor Jo Neal from London presented qualitative research on her team exploring the role of choice in opioid pharmacotherapy, and all of those kinds of human rights empowerment aspects that are so important, but concluded that, or explored the idea that the research evidence behind this idea is not as clear as we might like it. But here we have a value-based aspect that we need to incorporate into care. Dr. Beck presented this data on the wide variety and distribution of the choices in opioid agonist treatment medications used across countries in Europe. And in part pointing out the fact that this can't simply reflect individual choice, it can't simply reflect differences in clinical effectiveness, but lots of policy and structural factors affecting what medications are available to people in different clinical settings. Dr. Marie-Ève Goyer from Montreal and her team had a poster summarizing this clinical resource, which to my understanding is the first English language resource at least in prescribing guidance to use slow-release oral morphine for opioid agonist treatment. It's increasingly common in Canada. It's endorsed as kind of a second-line option for opioid agonist treatment beyond buprenorphine and methadone in the Canadian guidelines, and I believe in the UK prescribing guidance as well, but definitely underused. Until now, in Canada at least, we haven't had access to a comprehensive resource on applying this. So I know in some countries it is illegal to use slow-release oral morphine as opioid agonist treatment, but in others it's legal, it's just underused. So perhaps a resource to help with advocacy as well. There was a dedicated session on safer supply prescribing. We've had some back and forth and discussion on whether safer supply should be a form of treatment, whether safer supply is too medicalized when it's used in the current OAT systems. But overall, there was promising quantitative data. Dr. Sereda presented data from her clinic that was just recently published in the Canadian Medical Association Journal, showing declines in healthcare utilization and promising quantitative data there. And then Alex Holton from Caput and the National Safer Supply Community of Practice showed us a summary of qualitative evaluations of safer supply programs in Canada that showed, incredibly positive, promising, powerful findings. So again, we have a situation where there's a human rights argument that is valid, but in a system that's medicalized and where the quantitative evidence is still emerging. The next batch of presentations I want to highlight involve the integration of substance use and infection treatment services. There was examples of great programs that were incorporating harm reduction principles, offering a menu of services in a single clinic setting, often through a mobile outreach clinic, options, choice, and the ability to prioritize, as I mentioned at the beginning. Examples of treatment on demand, so when somebody's ready and interested in a service or a treatment, they're available to get it right then and there. And the message again that it's not enough to focus on one single disease. It's not what people need. So again, from Dr. Goyer's group in Montreal, this was one kind of framing of how to make this better and hopefully also a potential advocacy tool. They're doing clinical practice guidelines for opioid use disorder treatment, and as part of that, they're suggesting there should be a minimum basket of services for people who are engaging in these treatments that goes far beyond the OAT prescribing, and that was a theme that Dame Carol Black was speaking about today. So in addition to OAT, incorporating harm reduction, incorporating sexual and reproductive health services, incorporating preventive health care, that this should be the basic standard, and hopefully this document can be a tool for advocacy there. Dr. Harris and colleagues are presenting on their work another hopeful advocacy tool on improving access to opiate agonist treatment in hospital settings in the UK. So this is about creating a safer environment where people can access medical care that they need instead of a hostile environment where people are forced into withdrawal and undertreated pain when they have severe infections. So again, trying to push up the minimum standard of care. Obviously, if the standard is so poor, it shouldn't be this hard, but this is a needed document, I think exciting. I'm going to conclude with a couple of randomized trials that were presented here, highlighting the power of moving outside the clinic and offering services in innovative places where people are already accessing them. Benjamin Eckart's team from New York presented a series of studies, really exciting work. That this one was published now, I think, in JAMA Internal Medicine, offering DAA treatment in a syringe service program setting versus facilitated referral, offered in much higher rates of sustained virologic response. And this is something that in my setting we're not typically doing. We're waiting until people are coming into clinic, or that's where we're meeting them anyway and offering treatment. So I think this kind of outreach is definitely needed in clinical services. Also from their team, a separate study, they offered for young people in syringe service programs, attending syringe service programs, same day evaluation, confirmatory laboratory testing, and treatment initiation with a 7-day pack of medications to get started. And this was just a pilot trial, but promising, with higher rates of SVR in the group that started same-day treatment. And finally, from the randomized trials, Dr. Midgard presented on opportunistic treatment in the hospital for people with hepatitis C, and found much higher rates of treatment completion in people who were offered immediate treatment while they were hospitalized, compared to, again, a facilitated referral upon discharge, which is the standard of care in my setting as well. So these are the key questions, again, that I've been reflecting on. I don't have answers. There have been some very valuable perspectives shared from people who use drugs that I'll be thinking about for a very long time. Danielle Russell's presentation on caring for skin and soft tissue infections and the power of incorporating transformative justice into clinical settings is one of the ones that I'll be thinking about for a long time. And some of the ways we can try to thread this needle between doing what we can within a medicalized model, but then also getting out of the way when we're not needed as clinicians. And I'll just conclude with this slide here. Dr. Sarita shared a quotation from her friend who uses drugs, again similar to one of Sophia's conclusion. What if instead of talking about hard-to-reach patients, we flip that around and talk about hard-to-reach doctors, or hard-to-reach services, or services with dumb barriers or restrictions on access, or a system with shitty attitudes? So I think clinical science needs to account for these problems as well. Thank you.
Thank you so much, Tommy. That was an excellent, comprehensive overview, and bang on time as well, so that's impressive. Next up, we've got Brendan Harney, who's a PhD student and research assistant at the Burnet Institute in Melbourne, Australia. His work focuses on elimination of Hep C among gay and bisexual men, people who inject drugs, and particularly the evaluation of nurse-led and community-based Hep C treatment. So Brendan's going to talk to us about models of care.
Great, thank you so much for the opportunity. I attended my first INHSU conference in Portugal in 2018, and I never expected I'd be up here doing this, a few years later. So thank you very much for the opportunity to do so. So this is going to actually go really well with Tommy's, because I ignored all the randomized clinical trials for mine, and I'll come to the reason why shortly. So in Denmark, we know what works. The community knows what works. In Denmark, they've got a bus, they test people, so on and so forth. You all know this, but I have a question. Why are we still referring people to another clinic for evaluation for treatment workup? It does work. You can see here, I won't read it all, but of these people, of the 114 who were RNA positive, 80 started treatment and the majority were cured. One of the things that was highlighted is the fact that, a lot of our healthcare systems are racist, so the non-Danish people with no access to healthcare were a decent proportion that didn't get treated in this model of care. Shifting to Malaysia, so as everyone will know, a low and middle income country, This is their whole process. Just like to point out, we don't need to do fibroscans. They only did APRI and FIB4. Treatment initiation, they did refer to hospitals, but only in, decompensated cirrhosis and Hep B co-infection, which I'm sure you all know why that would be. So of these people, about 10% had cirrhosis, so it kind of justifies not actually having to do fibroscans on everyone. Basically, everyone of the 156 who had RNA detectable, the majority started treatment. 71% received treatment on the same day. This is in Malaysia, a low and middle income country. Why are we still not doing this in high income countries? We can learn from other countries. It's not the other way around all the time. Again, about 3/4 completed treatment. The majority of those returned for SVR, and again, the majority were cured. So shifting to Australia, Sydney. So Phil Reid presented this on behalf of his team. And again, going out to the community, going out to where people are, not waiting for people to come to you in buses, using all the tools that we have, incentivisations, peers. I'm pretty certain Phil still has to write the scripts, but I'm pretty certain he never sees any of these people. Again, we don't need doctors involved in everything. Still a small number of people involved in this, but you can see here of those who, you can read all the details there, but getting to Tommy's point, we need to think about this is a model of care. We're never going to be able to do a randomised clinical trial on this kind of model of care for a variety of reasons, but we need to obviously do the evaluation still and understand what people like about it, which is important because at the end of the day, it's those people that we're trying to help. Again, to Tommy's point, Hep C and Sophia's, Hep C is one thing. Obviously, for a variety of reasons, people who use and inject drugs experience a multitude of issues going on in their lives, including due to structural vulnerability and political choices. So we saw some data from Spain, from Madrid, looking at STIs among people, female sex workers in Madrid. And what we saw was that the STIs were much higher among the female sex workers who use drugs. Are they engaging in more risky behaviour? Possibly, but again, criminalisation of both Spain's actually about to introduce sex work laws that will be probably even worse for these marginalised people. So again, political choices. Integration of models of care. So from my future colleagues in Montreal, we saw that the Schulman Addiction Medicine, they started telehealth during COVID, but we know a lot of people who inject drugs, and the most marginalised of people who inject drugs don't have phones to access that. So they worked with Cactus, NSP, one of the oldest, longest running NSP in North America, to basically work in partnership so those people could go into Cactus, which remained open during COVID despite the lockdowns, to work together to address that issue that they don't have phones to do telemedicine. Some of the data on the prescribed medications. Sorry, I was supposed to have a slide on the Hep C stuff there, but obviously I did this too late and missed that. So prescribed medications, going across to the other side of Canada, again, safe supply or safer supply. So the prescription of opioids and stimulants in Victoria and BC. Obviously something we need to think about more as well. And at the same time integrating this, so we're addressing, that's the, prescribing those, but also hepatitis C treatment there as well. So it'd be remiss of me to not include some of Tommy's work, because I assumed he wouldn't include it himself. So this is just straight up safe supply during COVID at homeless shelters in Halifax, Nova Scotia. And this is just, the various substances. So we know, obviously, opioids are an issue, but we clearly know stimulants. People who use and inject drugs also drink alcohol, and this is a great slide from Tommy to just show the breakdown of all the different combinations that we need to be thinking about to address what people need. So this might partly answer the question, we need to move beyond randomised clinical trials, because we know for a fact that probably the majority of the work we do is never going to be a randomised clinical trial. There's a lot of great work being done that are not randomised clinical trials, but we need to think about ways to evaluate this. So this is a poster from Binta Sultan from UCL in London of a realist evaluation. So this moves beyond the concept that everything needs to be randomised, but you do need the real thought process behind it of, you know, understanding how it works. And I think this is critically important because we constantly see, well, it's been pointed out that the low evidence base for harm reduction when we're using the kind of, gold standard evidence. There's a lot of writing on there, but great poster, check it out. In the opening session, El Story, I think, summed it up very well. It's the political determinants of health, not the social determinants of health. All of the policies that we have are political choices, including, as I said, why do people need to be referred externally to get treated for hepatitis C when we know they don't need to have that? That's a policy choice, that's a political choice that affects models of care, affects everything we do. And with that, thank you very much.
Great, fantastic job, Brendan, really appreciate it. Our next speaker is Dr. David Whiteley. So Dave is qualified as a registered nurse in 2005 and subsequently built a clinical career within the fields of bloodborne viruses and sexual health, then moving into academia and joined Glasgow Caledonian University in 2021. He's a qualitative researcher with interests in Hep C and drug and alcohol use. So welcome, Dave.
Thank you. Thank you for the opportunity to do this talk. Thank you everyone for staying. I'm somebody that if I have a presentation to do, I normally have it done 2 weeks before the conference so I can just relax and chill. And so I've been asked to do a presentation at a conference that I'm already at, almost blew my mind. So apologies for relying heavily on my notes, and also apologies for the lack of slides. This is it. Yes. I should leave now. So I've worn a couple of different hats during this conference, listening as a researcher, but also listening as a nurse. And the importance of the relationship between people who use drugs and healthcare providers has underpinned a lot of the discussion over the last few days. And it's something that resonated with me from previous experience in practice. Specifically, the concepts of trust and mistrust of healthcare professionals by people who use drugs, but importantly, vice versa. And that's threaded through a number of presentations. On Wednesday afternoon, we heard from Danilo Falzon, who presented a study exploring potential models of drug checking in Scotland. A key finding of that work was the trust that people who use drugs often have in third sector services, as opposed to the mistrust felt towards statutory services available through the NHS. Trust and mistrust were also integral to Lise Lafferty's presentation on Thursday, which focused on how people who inject drugs engage with services upon their release from prison. She highlighted a need to foster encouragement and empathy post-liberation and the complex role of honesty in that context. Healthcare is a social activity, and it requires social capital to effectively take part. Trust is a fundamental part of that, and building or rebuilding trust between healthcare professionals and people who use drugs is vital. So what can we do? That's a big question for a short talk. But we've heard a lot about the role played by peer support workers during this conference, and their work must be integral to this story. Peer workers serve as bridging links between people who use drugs and healthcare teams, negotiating trust and acting as advocates for both service users and service providers alike. These are difficult, complex, and highly skilled roles, and that was emphasized this morning by Magdalena Harris in her presentation. But it's not something that's always acknowledged. As Jason Wallace stated in his opening address, peers need to be paid appropriately for the vital work that they do. In addition to the concept of trust, we've also heard the all too familiar refrain of stigma echoing through many presentations over the last 3 days. We heard this morning about stigma's ability to socially exclude gay and bisexual men who use drugs within local gay communities in Australia. We've also heard about the continuing impact stigma has on access to hepatitis C care and treatment and its role in reinfection. Alison Marshall unpicked the complexities of double stigma for women who use drugs that are living with hepatitis C, exploring how they perceived being judged more harshly by health services due to their gender and injecting drug use. These examples are by no means exhaustive. The diverse presentations at this conference feed into the growing body of evidence that emphasizes the multiple impacts stigma has for people who use drugs. It affects individuals directly, impacting well-being and mental health, but also the ability to seek out and engage with support and treatment. Tommy Brothers and Teresa Flynn, in their separate talks, both alluded to the social context of risk and how stigma and discrimination loom large in the risk environment. Stigma marginalizes already marginalized people. It intensifies vulnerability and isolation. We know this. But further, it also limits the response that we make. And that point was brilliantly emphasized by a number of presentations over the last 3 days. For example, Magdalena Harris emphasized how stigmatizing language is ingrained in NHS policies in England, actively contributing to the prevention of timely opioid substitution therapy for people in hospital. A similar story was heard from the choice investigation in America, which found a lack of standards and unclear policies for OST in hospitals were rooted in pervasive stigma that permeated care. We've also heard from Tessa Parks, who illustrated how stigma is an important barrier to the implementation of drug consumption rooms here in Scotland. Stigma reduces the public appetite to help marginalised people and communities, and in doing so, it limits the political will and level of investment to deliver services that are fit for purpose. Tackling the pervasive impact of stigma needs to be high on our collective agendas, as its tenacious influence continues to regulate the ability of individuals, of communities, and of networks like this one to respond. There were chinks of light, though. Carla Trelaw explained earlier today how an arts-based intervention in Australia had a positive influence on attitudes of the general public towards people who inject drugs with prison histories. The importance of thinking creatively to make our research findings accessible and, importantly, impactful was clear. However, the study comes with caveats. Whilst improvements in attitudes were reported, reductions in stigma occurred in specific and limited ways. So what of larger interventions? What of political responses to help remove the societal shame of drug use? What of decriminalisation? That's been a regular theme throughout the conference and was the question Niamh Eastwood addressed on our first morning together. Niamh's inspiring talk emphasised how the push for decriminalisation must be the backbone of everything that we do. Decriminalisation of drugs saves lives and it saves money. And if governments don't much care about the first, we know they're extremely keen on the second. But as Niamh eloquently explained, decriminalisation is not enough on its own. Reform needs to be based on public health principles to repair the damage that has already been done. On Wednesday morning, Marion Selfridge also talked about stigma alongside racism and discrimination as a barrier to accessing safe or safer supply in Canada. I've learned a lot about safe supply over the last few days. But stigma, racism and discrimination remain barriers to access as the same policies and structures are employed to roll out safe supply that have been used for OAT. A reminder, if it were needed, that new initiatives call for new thinking from the top down to engender systemic change. We have to demand more than sticking plasters, tweaked and rehashed policies to protect the health of people who use drugs. Anna Conway and Shelley Walker illustrated this well in their separate talks focused on people who use drugs in Australia during the pandemic. Anna described how this group became a counter-public, not imagined or accounted for in the state response. Shelley's account brought this to life, describing the impact of enforced lockdowns on access to housing services, drug services, sources of income, and social support. both speakers emphasized the need for population-specific responses to big events or public health emergencies. One policy does not fit all, but it feels like all policies during COVID rarely fit the needs of people who use drugs. That's not to undermine the innovation seen during COVID that's been celebrated over the last few days, both in presentations and in posters. This brief rundown has only skimmed the surface. I've barely mentioned the brilliant social science focused on prisons and naloxone, or indeed Jo Neal's thoughtful and eloquent consideration of choice within drug treatment. Indeed, choice was another important concept that wove throughout our time together here, and photos from the My Choice project displayed in the exhibition hall have provided a constant reminder that personal choice must be the foundation of ethical and humane drug treatment and policy. My highlights may not have been yours, but whatever you take away from this conference, I hope you leave feeling as impressed and as inspired and as motivated as I do. Thank you for your time.
First of all, just a massive thank you to the rapporteurs. Having done it several times, I know how much work it is, and you guys all did it in a slightly different way, but really amazing. And it was, so thank you so much. It's a thankless task sometimes. So maybe a round of applause for. So I just wanted to see, show of hands, is this the first international conference you've been to since COVID? So yeah, pretty amazing. And I think it was so wonderful to connect with friends and colleagues that we all haven't seen for a long time. It's emotional. It's been a big week. And yeah, so it's been great to see everyone. My last conference, it's kind of crazy to think about it now, but was actually in South Africa, in Cape Town. And that would have been February 2020, actually end of February 2020. And we were talking about it at the conference. Oh, have you heard the news? There's this virus going around. And I went, oh, no, everybody, no, it's not a big deal. They're probably making a big deal about things. And I remember having these conversations, and I was like, all right, Jason, are you scared to fly? Why would I be scared to fly home? Like, no, I'll be fine. But I'm sure stuff was circulating around on my journey back to Australia. And actually, but I really treasured the time in Cape Town. Many of you might not have been it. It was a smaller regional meeting. So I guess I'll draw on a couple of reflections, but I think one of the highlights, starting with this highlight, I guess, of the conference was actually chatting with Angela and Angela from Sampwood and Koketso last night, and them just sort of feeding back how much that conference has had sort of a lasting impact in South Africa. So it was really great to hear that, Ange and Koketso. It's so wonderful that you could make this. I don't know how many people know, but this is Koketso's first time outside of South Africa, and so it's amazing to have him here. And to see, how far you've grown over a couple years, it's fantastic. So we made a move, the INHSU, to change the name and focus more broadly on the health of people who use drugs beyond just hepatitis C. And I'm very happy. I'm quite proud. I think it's been integrated really nicely. I hope you feel the same. I'm really proud of the increased community involvement. So big thanks to all the community people and everyone who helped to pull that together. And also increased early and mid-career researcher sort of representation and connections around that. I'm really impressed. The scientific quality continues to go from strength to strength, and it's amazing to see now, you submit these abstracts, and now we're seeing papers that are being published in Lancet journals and JAMA journals that are have already accepted and in print by the time we're at the conference because we're submitting things so far before. So it just speaks to the strength of the science. The Jude Byrne Award was a highlight for me. It's Jude played a special role for me as a sort of friend and a mentor. And so it was really nice. And both Yedi and Danielle, massive congratulations to you guys. And really excited to see where you guys go from here. Connecting with Care and my choice, a big thanks to Connor Ashley. And I was remiss to not also acknowledge the INHSU team, in particular Liv Dawson, for all their work and working with Connor to sort of pull all that stuff together. Look, it was a tense morning session. Elephant in the room. It was tense. And I think, which is good. I actually, in some ways, I think as long as the discussion, for those that you were here, and I think it actually wasn't intentional. I was chatting with Don Dillon, and when we put those presentations, it wasn't intentional to actually have those contrasting sort of perspectives. And then I was like, oh, geez, okay, oh, shoot, okay, this is where this is going. But I actually think one of the things about INHSU is that I think we need to have a space to have difficult conversations and just do it in a respectful way. And I think that's the only way that we'll be able to sort of push things forward and bring people together to be able to understand, at least if you can understand where the other person is coming from or from that other view, and respect that. We won't come to agree, but if we can respect where they might be thinking, I think that's hopefully what we can continue to do around difficult topics at INHSU and to bring the different stakeholders together around on it. I think that we want to continue to support community involvement. I think we've done well, but I don't think that I think we can always do better. There's not enough community, but I think it's good. And I think the other thing, I'm reflecting on some of the things I think we can improve. And I think that it's absolutely blatant, the lack of low and middle income country, both talks and representation at the conference. So it's something that we already discussed with our new committee for next year, and it's something that we're going to work really hard to address because it's obvious, and apologies maybe, but look, we can all, again, we'll just continue to improve. So if you like the conference, please tell people about it and bring a friend. You know, I think the only way we'll continue to increase is if we get everybody working in the field to be here. I actually like the size, so I don't want it to get too much bigger. It's a good size. And actually, that's the amazing thing about in Cape Town. It was a couple hundred people, and it was actually a really nice size. You got to actually spend lots of time chatting with people. If you didn't like something, tell me. Tell us. Tell the INHSU staff, please. From either from INHSU or ASHM, complete the evaluation form. People, I'm not going to listen to complaints if you don't take the opportunity to tell, and we'll try to listen to what people say, but we always want new ideas, innovative ways. If you want to create a session, send an email, please, because we want to just continue to improve. Thanks to all the speakers, the chairs, the rapporteurs, the INHSU board, the community committee, so Jason Wallace, Rachel Halford, Sione Crawford, Louise Hanford. You guys, I know how much work you guys have put into this, and also the early and mid-career researcher community, so Behzad Hajarzadeh, Adelina Artani, Lise Lafferty, and MJ Stowe. These guys on their own put so much effort into trying to pull things together, and just really appreciate it. Obviously, we have the international committee, the regional committee, the core committee for the conference, and in particular thanks to Sharon Hutchinson, John Dillon, Dave Little, Judy Chang, and Matthew Hickman. Maybe just a round of applause for all of them. Monthly teleconference calls at random times in night. Just really appreciate it. ASHM, thanks so much to Alexis Apostolakis, who's the CEO, all the support. ASHM does an amazing job running this conference, and the conference team, so Nadine Giatris. And a massive applause for Amy Sargent and Leah Manicom. Are you guys here?
There, it's up.
Can you please stand up? A little bit louder. All the emails, all the stuff, it looks like it's all seamless. They're like in the background, putting out fires, making sure it's looking seamless. So thank you so much. And then a massive thanks to the INHSU team, Brooke Nolan, Liv Dawson, Nikita Bracken, and Emma Day. We've built such an amazing team, and without them, none of this would happen. You wouldn't see all the stuff in the background, the side meetings, that's all them helping with connecting with care, all the media stuff, Brooke. So, and obviously, Emma, it's made such a huge difference having you guys as a team. It's made it so much easier. So I will stop there. I think I'm about on time, but just I hope you guys had a great week, and I really appreciate everyone for coming. And I'll hand it over to Sharon.
Okay.
So thank you.
Okay, I'm going to keep it brief for everyone, and I think there's a wee bit of overlap there between Jason and I. I'd just like to thank everyone for their incredible participation. And, oops, did something happen there? For their incredible participation and engagement in this conference. I think we're in somewhat uncharted territory, having hosted the first INHSU event since the pandemic. I'm a little bit unsure how things were going to play out, but I think it's fair to say that the INHSU family really didn't disappoint. They turned up en masse and delivered. And I think it's just to acknowledge, I was so impressed by the sheer breadth and quality of presentations, workshops, and range of contributions. You can really tell how much effort and thought has gone into preparing for this. I think that really shone through. And in so many instances, people, our community members have been incredibly brave, I thought, in coming forward and sharing their experiences and stories. And it's these contributions that I think and exchanges that have really made this event such a success in my eyes. And we in Glasgow, and indeed for the rest of Scotland and the UK, I think we've truly benefited from this event. And the broadening out of the scope and the focus of the conference came at the right time, I think, for us, and it really facilitated getting a much broader range of partners beyond those that are working really in hepatitis C. We had a broader range of partners that came along to the conference, and also the key pre-conference events as well. We had really great attendance at those, and it's given us a forum for it to have those broader joined up discussions, learning from the vast experience in the audience here, making all those important connections, and no doubt lots of ideas to take away and work on in the future. And I think it's been really great to hear the initial feedback from everyone, people saying that they've been really energized by the experience of coming together, and I guess that's been much needed given what's happened over the past few years. And I guess finally, I just want to say a really heartfelt thanks to Jason, and also the INHSU team and the ASHM team for all of their work and dedication. I've had the privilege really over the past year to work with these guys and had a glimpse of the sheer amount of work that goes on behind the scenes to bring us all together on an annual basis. So I think I'd just like to acknowledge that, and if you can all join me in a final applause.
And I think to end things, and thank you so much, Sharon, Philip Brugman and Erica Castro.
Good evening. It's great to have the last word, even we haven't done much so far. It was an absolutely great conference. We highly appreciate it. Thank you very much to the whole Glasgow team. But after INHSU conference is before INHSU conference, and we already started since quite a while to plan for INHSU 23 in Geneva. And the Glasgow team set the bar quite high, I have to admit, but we take the challenge. And just one of our plans for Geneva 23, beside continue to expand from the focus from hepatitis C to the broader health aspects of people who inject drugs, also to collaborate closely with all the health organizations based in Geneva, with the goal to provide you a very global perspective, including low and middle income countries, on health and healthcare for people who inject drugs at the next INHSU conference. So I'm very happy to collaborate on this conference and do the planning with my colleague Elika Castro from Lausanne, with Nicholas Luhmann from WHO, Linda Montanari from EMCDDA, and Anton Basenko as a community representative in our core committee. So hope to see you in Geneva, and don't forget to bring your dancing shoes with you. Thank you.
Have a great trip home.